Hi, good evening, everybody. My name is Dr. Sandeep Diwan. I'm the Director of Critical Care Medicine at Fortis Memorial Research Institute, Gurgaon. And I'm also the Managing Director of Health Training Asia, a company dedicated to the concept of telemedicine and healthcare trainings. The today's topic that we are going to deliberate on is exploring the scope of tele-ICUs in India. Now, if you talk about telemedicine in India, it's still in its infancy, and particularly as the digital health is gaining momentum in various parts of the country. People are now gearing up to the concept of telemedicine and how patients can be treated. It does need some infrastructure, it does need some clinical expertise before one can venture into telemedicine. So today we'll all discuss about how the concept of tele-ICU has evolved over the years in India and how it can be beneficial for improving the critical care outcomes of ICUs, which are particularly situated in Tier 2 and Tier 3. Now, if you look at the gap in the Indian healthcare, it's huge, and we all know that we cater to 16% of the worldwide population. We also cater to 18% of the worldwide mortality. So that's a huge number. And 20% of the worldwide morbidity sits in India, which is basically because of communicable diseases and other critical illnesses. But if you compare it with the investments, our healthcare investments are less, quite less, and we only spend about 2% of the world GDP is spent on healthcare, while we spend only 1%. So our healthcare spending is less as compared to what our needs are. And actually, that's not the only challenge. The other challenge is that if you look at the doctor-patient ratios in developed countries of the world, there are about 2.56 doctors per 1,000 population in USA. And if you compare it with the other countries like Brazil and South Africa, it comes to about 2. Unfortunate part in India is that in spite of the huge stress given by the governments in opening new medical colleges, and a lot of things is happening on that front, still there's shortage of doctors in India, particularly the specialist doctors. We're not talking about the junior doctors here. We are also considering the specialists who are experts in their field. And as we know, tele-ICU is intensive care is a super specialty. So finding a critical care expert in remote parts of the country is a challenge today, and will always continue to a challenge, at least in the short future. So if you look at the problem statement, the specialist deficiencies is definitely going to affect the outcomes of the patients as far as ICUs are concerned. If you combine with the expectations of the various stakeholders in the healthcare environment today, what do the patients expect? The patient expects a quality and affordable ICU care. There is definitely a need for a 24/7 intensivist that needs to be there to run that critical care unit. We all know in intensive care that if you do few things in the first 1 hour, which is called as the golden hour of critical care, if you do certain things which are right, you can actually make a lot of difference to the outcome. Patients also want convenience of service. What do you mean by that? When a patient moves from a Tier 2 or Tier 4 city to a metro city, it's not only the patient's family has to move. So given a choice, if the same healthcare facility is available at the smallest town, the patient would prefer to stay there because it also incurs huge cost. Plus, transportation of these critical patients in ambulances is also going to be more risky. And obviously the patients expect the value for every penny that they are spending on the healthcare. So as we understand, the patient expectations are growing. What do the physicians expect? Now, the doctors and the nurses expect that all the critical care patients should at least be seen by a 24/7 trained intensivist. And this is as per the leapfrog recommendations that if you have a consultant critical care in your ICU, the outcomes are much better than when you don't have. They also expect that the intensivist should be able to recognize early warning signs and raise an alarms whenever the clinical condition deteriorates. Various SOPs and quality bundles should be implemented and compliances related to good critical care management should be in place. One should have access to patients anywhere, anytime. Multidisciplinary team meetings should be a call away, and the physicians who are working in the ICU should be able to upgrade their skills, particularly intensive care skills, under the leadership of a critical care specialist. If you look at the third stakeholders, which are the hospitals or the administrators, they are looking at better ICU outcomes. They are also looking at patient satisfaction. And in this era where the resources are getting more and more limited and the healthcare budgets are going up and up, they are looking at efficiently running the ICUs in the form of decreasing the average length of stay, cost management, and making the right use of intensive care resources. So overall, if you look at the whole atmosphere of healthcare, all the stakeholders have something to say as far as intensive care unit is concerned. So what is the solution? Now, there's no doubt that the best way is to have a critical care specialist on the ground, one who is a trained intensivist. And when I mean a trained intensivist, mean who has done a proper training in critical care post his post-graduation, and he's able to run an intensive care efficiently. But if you don't have a trained intensivist all across the world, and particularly in USA, where this model started, tele-ICU has come up as an alternative. Now, we are not saying that digital health should replace the doctors. A physical doctor who can be there at the site is the best one. But if you don't have a critical care specialist, rather than having nobody to see the patients, it's always better to have a critical care specialist from a remote location monitor these patients. So what tele-ICU means? It's nothing but a remote patient monitoring system. So you have a consultant who is sitting at a command center, and the way you guys can see me, similarly the spoke ICUs or the doctors there or the nurses there can talk to the critical care specialist who is sitting in Delhi. It is aided by two-way audiovisual communication. In the webinar that we are doing right now, it's mainly one-way communication. I am speaking, you are listening. But when you are doing intensive care rounds through remote monitoring, it's a two-way audiovisual communication and the doctors can chat to each other. It's a blend of medicine with digital technology. The best part is that it is available, the service is available 24/7, 365 days. So even if there are units where you have a critical care specialist, but there's a limit to the human mind ability, there's a physical limitation. Sometime the critical care specialist will go home, maybe at 5 o'clock, 6 o'clock, 7 o'clock. So what he can do is that even if you have an intensivist, the remote monitoring, particularly in the night, can happen through the intensivist who is sitting remotely, and if there's anything wrong with the patient, he can raise an alarm. This is proven to reduce mortality rates. We have published enough data in the last few years to see that when you establish a tele-ICU monitoring system, the mortality decreases to as low as 50%. And we have also documented that the morbidity also reduces by 30 to 40%. So if you look at the medical outcomes, it is bound to help. Now, if you look at the gaps, particularly related to critical care in India, we had talked about it in a general healthcare scenario. What is critical care? Critical care is 24/7 management of patients, which includes monitoring, diagnostics to support the failing life functions. If you look at the infrastructure, 5 million patients require ICU care every year, and very less number of ICU beds available, although this number may be increasing every day because more and more ICUs are opening now. but there's a huge shortage of ICU specialists. And we all know, if you have read books on patient safety or you've read checklists, that a lot of patients die because of ICU related mistakes. Now, this is not medical negligence, but it is just that the early warning signs or the time when the intervention needs to be done is missed, and some data say that approximately 10% of deaths can be prevented if the early warning signs can be caught. If you look at the manpower shortage, less than 15% ICUs in India receive dedicated critical care specialists, and ICUs demand huge resources from the hospital. Every budget of the hospital, 20 to 30% is dedicated to intensive care. 25 to 30% of hospital beds are earmarked for ICUs, and 40% of the patients who get admitted in the ICUs end up either borrowing money, selling assets. And there was this report from, I don't remember whether from which NGO, which showed that if you have somebody admitted in the ICU, your level in the society goes one down because you have to borrow stuff to manage the ICU resources. So the costs involved are huge. So that's why if the patients can be managed at the site, at remote sites with limited resources, I think that may go a long way in not only improving the critical care infrastructure but also decreasing the costs. So as I told you, it's a 24/7 ICU monitoring system aided by real-time two-way audio-visual communications. Now there are three different entities who work in tandem to give a tele-ICU system, and it's a collaboration between hospitals, critical care specialists, and patients. And these are the three group of people who are actually doing this thing to reach the far end of the ICUs. Well, we are talking here about ICUs, but when you're looking at the far end, you can reach as far as the community health center, you can reach as far as the primary health centers, because it is completely expandable solution and the reach is huge. With the improvement in the network, with the improvement in the technology in the last few years, it's become simpler now to run these kind of systems in India. And as we are talking, we can see more and more people exploring digital health and telehealth as a mean of patient management. This is what a typical command center looks like. This is my photograph in younger days. You will see a lot of screens. Looks like a cockpit where every bit of data from the patient is coming. You can see the patient monitor. One has access to the ventilators. One has access to diagnostics in the form of radiology, in the form of labs, and once you have collated all the data, one can actually send a report or an advice to the doctor there to do certain things. This is the latest innovation. What I had shown you was about 7 years ago, and this is what now latest happens. This is a advanced consultation e-rounds remote monitoring system, which is from GE, which is set up in the command center. And you can see it's a combination of 6 screens, which is showing all the patient related data. And as the outcomes of the tele-ICU I was telling you about, it has been proven to reduce mortality, reduce length of stays, reduced errors, improved standardization, reduce ventilator days, and obviously reduce costs, because ultimately at what cost are you giving that ICU service to the patient matters a lot. So as I tell you, any tele-ICU system should be accessible, it should be affordable, and it should be improving the quality of critical care. And these are the 3 major concerns when we are talking to ICUs in tier 2 and tier 3 or tier 4 cities. Quality at lower cost, or quality at an affordable cost, and accessibility are the 3 main demands that we see. So if you look at the accessibility part, as I told you, there's the concept of golden hour. So once unit is connected to the command center. The command center works 24/7. The critical care specialist is available there. The doctors from the spoke or the nurses from that small ICU can talk to the consultant anytime, and even when the patient is deteriorating or there's a new patient, the patient help can be given immediately. When the junior doctors and nurses are rounding with the consultants, although they are sitting remotely, but during the rounds, their also skill gets upgraded, their concepts of critical care improve. So over a period, we see that they also become good in certain aspects of intensive care unit. So it does improve skill. It does improve the capability of the doctors and nurses to handle more critical patients. As far as affordability is concerned, it is delivered at very lower price points, to as low as 600 rupees per day. What you generally are trying is to prevent transfer of patients who are being treated at spoke site. Now, there's two ways the spokes will be benefited. One, they can actually start taking more critical patients. Right now, when we talk to a lot of ICUs in tier 3 or 4 cities, they say that I'm afraid to take ventilated patients because my doctors and nurses don't know how to manage the ventilator. Or they say, I do not take critical patients because I don't think I have a consultant who can look after these patients and guide my nurses. So these patients ultimately either go to larger cities for their management if they can afford it, and if they can't afford it, they go somewhere else. So what tele-ICU does is that it prevents these costly transfers from smaller cities to larger cities, and also enables that unit to manage sicker patients, more critical patients at the site. And obviously, since it works 24/7, 365, it enables access anytime, every time, and regardless of the economic class. The third thing that the tier 2 cities need is the quality of critical care medicine. Well, critical care has improved leaps and bounds in metros. You will see good intensive care units, qualified consultants, big teams. Nearly every big ICU has about 90 to 100 beds. But as you move even about 100 kilometers beyond metros, you will find that the ICUs struggle, not because of the intent, not because of the infrastructure, but only because of the expertise in managing these patients. So if you're looking at the quality, because the consultant is seeing these patients, the mortality goes down, you can save more lives at an affordable cost, you can actually decrease the morbidity, and various SOPs can be implemented where the infection control in the ICUs and average length of stay can be improved. Excuse me. Now, what are the factors that help in improving these ICU outcomes? Some studies have been done on this. Why should tele-ICU improve outcomes? And if you look into the studies on tele-ICU, you'll find that it's basically early recognition of the warning signs. So in every part of medicine, you're taught that if you can find out the early warning signs just before it has become irreversible, the outcomes can be changed. So it's basically early goal-directed therapy and recognition. Even tele-ICU helps in timely institution of non-invasive ventilation, or initiation of mechanical ventilation. Because there's adherence to the guidelines, so the outcomes become better. Since the doctors are rounding with the specialists on a daily basis, there's constant training of ICU staff, which happens on the rounds, which includes doctors, nurses, and support staff. And the critical care quality bundles are applied. So these are some of the factors which have come into play while improving the outcomes of telemedicine or tele-intensive care all across the world. So if you look at the ways these things can be implemented, and we talked about the bundle approach, we have talked about the quality, we have talked about guidelines, we have talked about scoring. What are we aiming at? Ultimately, we are aiming at early decisions, good decisions, accurate decisions, and decisions that can actually make a difference to patients' lives. So this is what we are looking at. Whatever you do, the best benchmark in medicine and the hardest predictor of quality is whether you can save a life. So whatever we are doing here in the form of clinical jargon is actually to decrease the mortality, and tele-ICU has been documented to decrease it to the tune of 50 to 60%. If you look at the impact, and this is the data that some of the data we have generated and published in various journals, the first impact has been on the number of cardiac arrests in the ICU. A lot of times we hear this in the ICU ki when a physician gets a call from a junior doctor that sir abhi to ye patient theek tha, abhi ye patient expire ho gaya. The call is very difficult call. It generally comes at 3 or 4 a.m. in the night, and you've just reached home at 12 midnight. You're just taking a nap, and then you get this call. So and ultimately you have to explain to the family what happened, what went wrong. So all the effort that one does during daytime sometimes gets worn down by that unexpected cardiac arrest. Now we in critical care know that unexpected cardiac arrest can happen only in two situations. One is massive pulmonary embolism and sudden cardiac death. So what tele-ICU does, it actually reduces the number of cardiac arrests in the ICU. It not only decreases the number of cardiac arrests, but even if the cardiac arrest happens, it also improves the ROSC, or return of spontaneous circulation. So because early warning signs are being looked at, because there is a consultant available 24/7, because there is a second pair of eyes which is looking after these patients, so the number of cardiac arrests will definitely go down. And not only the cardiac arrest will go down, but you'll be able to save more lives. The second thing that we have generated the data from India is that you can actually decrease the infection rates in the intensive care units. We all know that India is struggling to maintain its infection control data. We have all kind of superbugs. Some of them have been infamously named after the capital city of the country, and it's high time that we raise awareness about decreasing the nosocomial infections which are happening in our ICUs. So if you appoint a tele-ICU system, if there's a consultant who is there to guide the doctors, there's definitely a huge potential to decrease nosocomial infection control rates and reduce the use of high-end antibiotics. Now it's easier to say, but it's difficult to do. What happens is that we have documented reduction of antibiotics to a huge limits, and if you see on the right side, post EICU implementation, the antibiotic usage has decreased from 79% to 60%, and carbapenem usage was reduced from 82% to 36%. So if somebody is there to help you, to calm you down, that every disease doesn't need a high-end antibiotic, it ultimately helps the patient, and you are sending your patients back at a much lesser cost. And that's why it's important to document that this is the benefits. As I told you, it has its own benefits in the form of trainings, and this is a benefit which happens indirectly because there's discrete interventions that happen, and this because the doctors and nurses in the night are responding to the advice given by the consultants from the command center. They are also upgrading their skills, they are also upgrading their knowledge, they are also upgrading their skill set. So that's why they raise up to the occasion and they are able to give better outcomes. As I told you, there's every modality of medicine should either fail or succeed on its own. So if you look at certain data which we generated way back 3-4 years back, and it was a project to actually decrease the incidence of infection rates per 1,000 days, okay? And if you will see the pre and post EICU, there was major impact in reduction of antibiotic usage. There was major impact in the amount of cardiac arrests, and there was major impact in the overall mortality in that intensive care unit. So these are the three strongest benefits that one can achieve from implementing tele-ICU. So if I were to summarize the benefits of tele-ICU, it's proven, it's predictable, it's sustainable. This movement started way back in 1999 in US, and it's now fully acceptable in India. We started with these 4 stakeholders in my initial presentation, and if you look at the patients, they have better survival rates. They are able to stay and get treated locally rather than going out. One can avoid expensive or dangerous transfers and save money. It can overcome weather challenges, geographical challenges, and since we all know that timely approach and time management of these critical care patients is important, that's why it will give huge impacts. If you look at from the hospital, the best would be, as I told, and I'll reiterate, is to have a consultant critical care specialist in-house. But if you don't have a 24/7 availability of a tele-intensivist, would be able to fill that gap. For hospitals, they can actually send their patients home, lower mortalities, fewer complications, better utilization of the beds, better patient care, reduction in the patients requiring transfers, and one can develop a paperless culture in the ICU. If you look at from the healthcare industry, electronic medical records, they bring transparency in healthcare. You can only leverage the existing infrastructure. You don't need add-on infrastructure to establish electronic medical records. Geographic footprints can be expanded and help unaffiliated healthcare entities improve performance and save more lives. If you look at the strategic impact, it has extended horizons. Intensive care can go beyond boundaries. You can reach actually to the last person in the line. As I told you, we are talking about intensive care here, but we can actually manage a primary health center patient also. It can actually increase the case mix of the hospitals. They can actually improve their critical care delivery models, and it's more retention and more satisfaction for physicians and nurses. This is the core team of HT Asia, which is involved in trainings and telemedicine. The key areas of focus, as I told you, is tele-ICU. It has to be affordable. It has to deliver quality, availability of intensive care, speed of ICU services, all should be driven. With this, I am at the end of my talk. I don't know whether you could think of any questions during the talk, but would strongly appreciate if we can have some questions from the audience. Thank you very much. Okay, so a very relevant question. How can we operate a low-cost ICU? Now, I don't know what you mean. I don't know where this question has come from, but I don't know what you mean by a low-cost ICU, because a low-cost ICU, there's no definition like low-cost ICU as per the medical terminology. Now, when I look at the low-cost ICU, see, there are various levels of ICUs that one can build. It's from level 1 to level 5. If you are looking at an ICU which should do a basic work, okay, then you are looking at a particular level of ICU. So the monitoring of that ICU should be according to that level. So the monitors that you buy, the equipment that you see, or the equipment you are purchasing should be according to that level. Suppose you are building up an ICU where you get a lot of trauma, then you are sure to build up a mid-level intensive care unit where you'll need a critical care expertise. So then the amount of monitoring systems that you need will be completely different. If you look at the low-cost ICUs, there are all kind of equipments available in the market, which can help you set up a low-cost ICU. but I will actually do it with a caution. How low can you go is we don't know. So the low cost equipment that you buy has to still throw good numbers, reliable numbers on which the doctors can respond. And how can you operate? Now, operate means how can you run? If you want to run a low cost ICU, you minimum you need 4 junior doctors and a consultant critical care specialist. Now the challenge is the consultant specialist costs will be high. So that is where telemedicine or tele ICU can help to deliver a low cost ICU model. Okay, what are the legal caveats in tele ICU model? Okay, now the legal structure in India in telemedicine is bound by 2 basic laws. One is the Medical Council of India law, which was established way back in 1956, and then we have certain IT related laws. Now the law says that as long as the 2 registered medical practitioners are talking to each other, this is purely legal. So if there's a consultant here or a doctor there and they are talking to each other, discussing a patient, and the consultant advising, there's nothing illegal about it. Point number 1. The second legality that comes is the safety of the patient data. In this era where everybody is so sensitive about data, so when you are running the data on a network, the network that we maintain is actually not a shared network. So the chance of that data getting out is almost negligible. This is the second part of the medical legal. The third part of the medical legal is suppose the consultant gives an advice and the resident applies it. Okay. Now the unit is responsible for the authenticity of the data. The consultant sitting at the command center is responsible for the authenticity of the advice. And the doctors who is managing the patient at the spoke ICU are responsible for application of that advice. So for example, if we give an advice of give fluid and if they do something wrong, the consultant here will be judged on whether the advice was correct, and the doctor at the site will be judged on whether the application of the advice was right. So that's why there's no oral advice goes, everything is electronic, it is documented, so that in case there's anything, one can retrieve the data and look at it. Okay, how you foresee this solution can help in skill improvement of nursing staff at the smaller hospitals? Now, it's a very good question because today we just finished a course where we had shared it live to few of the other centers. What we do when you are managing a tele ICU, there obviously when the nurses are working with the doctors, their skill upgrades. But once in a week, because the unit is completely connected to the command center, once in a week or twice a week, all the nurses of that unit, they gather in a common area, and the consultant from here teaches these nurses on various aspects of critical care. Now, these are the benefits which is huge for the hospital and the nurses, because sitting there in their city, in their hospital, they can be easily trained, for which they will never get if they were not connected. Otherwise, they have to move to metros to train themselves, which has costs of travel, stay, and the costs of the course. So yes, because the unit is connected, the nursing trainings keeps on happening at a regular intervals. That's why. Oh, okay. What are the best adoption guidelines for tele ICU? What defines success rates? Okay. Well, at this point of time, as I told you, there are no guidelines for tele ICU as such. Okay, but success rates are basically defined, as I told you in my presentation, in the form of whether you can save more lives. So when we set up an EICU, we see the baseline data of the ICU, and we look at the 4 major problems that as ICU is maybe suffering from. So some ICUs will say that I cannot take more sicker patients. So we compare after EICU whether they are able to take more critical patients or not. Point number 1. Second, some of the ICUs say, sir, my cardiac arrest incidence is very high. So that becomes another benchmark. We get the baseline data. Third, some ICUs say that, oh, I'm suffering from antibiotic rationalization because it's a lot of confusion of what antibiotic to give in the ICU. For them, we make different protocol and we work on that. So the success rates for certain ICUs will be different and certain ICUs will be different. But one thing which is definitely common is whether you can decrease the overall mortality in those intensive care units. Okay, is tele-ICU used in every conditions? Well, practically it can be used anywhere, as I told you, as long as there is connectivity. As long as the doctors are sitting at the command center, junior doctors are there at the spoke, and there is a connectivity, it can practically run in every condition, every environment to the remotest area of the world. John, what are the hardware requirements to set up tele-ICU? Does Critnex platform perform third-party providers that work in low-resource environments? Okay, I'll take the first part. What are the hardware requirements to set up a tele-ICU? Now, the tele-ICU needs 2 kind of systems. One is the hardware and one is the software. The hardware is basically to see the patients. So these basically consist of cameras which are positioned at strategic locations so that the patients can be seen. The software is the software which is installed in the intensive care unit so that the real-time alarms of the patient monitors can reach the command center. And that is how, when the alarms start coming to the command center, the interventions can be done in a faster way. So these are the 2 requirements, and the third requirement is the connectivity. The site and the command center need to be connected, which is not a difficult these days. So it's a very simple network. It takes three things into account. How can we see profitability in taking tele-ICU services from the remote site point of view? Now that's a very relevant question, because whenever we talk to the remote ICUs, there are 2 ways they look at it. One, they will obviously look at it as a cost, but how does it help them in making their ICU more profitable? Now, first thing is that because you have a critical care specialist, so you can take up more critical patients, which these ICUs will never be able to take. Point number. Second, because these ICUs are now connected to metro cities, or most likely, since we are based out of Delhi, so you are connected to Delhi, so you can actually brand this service in the local area so that you can stop the transfer of critical patients from remote areas to metros. So that's the benefit number 1. You will never be able to manage these 2 kind of patients. Those who have to go will go because you don't have the expertise, and because you don't have the expertise, you cannot take more sicker patients. So that's a profit on its own. The third thing is, once you save more lives, at 2 a.m., if there's a service available, and there are very few ICUs in small cities which will be doing the right things at 2 a.m. So if you're doing the right things at 2 a.m., your credibility goes up. If you save few ones, your reputation in that part of the city goes up. So you are viewed as a one-point destination for the ICU services. So this is the third way in which your profitability can go up. These are direct benefits. The indirect benefits are, you are sending your patients at a much lower cost. So your reputation becomes of an ICU which sends patients back to their homes, but it's not very costly. Second indirect benefit is because the infections are less, because the length of stay is low, that's why you open up your beds faster and you can churn them fast. And that's how the indirect benefits of EICU can be seen. Okay, the next question is, can trauma care be part of tele-ICU? Any kind of care can be part of tele-ICU. It can be trauma, it can be neuro, it can be cardiac, it can be surgical, all kind of, it can be even emergencies. It can be obstetric ICU. So any kind of ICU network or emergency area can be covered under tele-ICU. What are the benefits of physiotherapist in tele-ICU? Well, I don't know. Physiotherapy is something which tele-ICU doesn't cover. So I'm not sure whether I can deliberate on this question or what are the benefits of physiotherapist. Well, physiotherapy is beneficial in intensive care, there's no doubt. But can physiotherapy be done through tele-ICU? I really don't know the answer to that question. How many centers are currently working on this model? Well, there are a lot of centers which are working on this model at this point of time. We have centers which are there in India. We have centers outside India. We have in Nepal, Bangladesh, sites coming up in Kenya. So at this point of time, there are a lot of centers in tier 3 and tier 4 cities particularly which are working on this model. Ventilation cases need most attention. Can we have this solution for handling the ventilation cases? Well, yes, because ventilation is something which is quite complex, and the smaller units, they won't understand it. So we do a lot of interventions on the ventilation when we are managing these patients, particularly defining the ventilatory strategy so that the ventilation doesn't do harm to these patients and should actually be beneficial. What are the limitations you foresee for the tele-ICU? Okay. How well it is perceived by the government? Well, I don't know that answer, how well it is perceived by the government, but I feel because digital health is coming up in a big way, so I'm hopeful that the government will accept tele-ICU. Unfortunately, in any of the government projects, tele-ICU is not visible as a line item, but I'm hoping that with industry help and with people putting their case forward, the government will definitely be keen to put tele-ICU in one of the line items in their various healthcare schemes, because if you have to reach the last person in the line, which this government is very keen about, if you have to reach the people who are sitting in the remote areas of the country, and we are a huge country, I'm sure the government has to support this model in certain way so that it becomes a kind of expandable model. What are the limitations? Well, if you dig the literature of tele-ICU, whatever, if you Google it or if you read some studies, the main limitation of tele-ICU is the acceptance by the doctors at the spoke. So there are units which have done benefits to the tune of 80%, because the doctors in those units took up the tele-ICU in a big way. They took the benefits out of the project and they could really give good outcomes. But there are units where the doctor acceptance was less, and the data shows that the benefits were as low as 18%. So look at the huge range from 18 to 80%. That means that's the only criteria which determines, not the only, but one of the major criteria which determines the success of tele-ICU in our country and all across the world. The other limitations to the growth of tele-ICU is I would say the not having standardized equipments, because whenever the ICUs are being constructed and whenever the equipment is being planned, since most of the people who are not aware of tele-ICU, they would buy any kind of equipment, and then when they are thinking of tele-ICU, the equipment becomes non-compatible. That's why it's at the planning phase when you are constructing a newer ICU or you are thinking of upgrading your ICU, you can think of buying ICU compatible equipment, which is not very costly these days, And these are the two major challenges, because the equipment cannot be changed that frequently. Okay. As per your opinion, what is the price of this system is another question. Oh, sorry, there are a lot of questions. What is the price of the system? Well, the price of the system can be asked from the email that is given in this presentation, which is ajay.prakash@g.com. The system actually comes from a mix of software and hardware, okay, and the clinical services are given by the doctors. So I cannot. The price of the system is vary from beds to beds. So if you have a 5-bed ICU, the price will be different. If it's a 10-bed ICU, the price will be different. As the number of beds goes up, the price changes. But let me assure you, as the number of beds goes up, the price goes down. So if you are attaching more beds to your tele ICU system, it's like a telecommunication model where the prices will be better, because it's actually the volume of the beds that they are looking at. How do we connect with your teams for the services? Now, as I told you, the last slides is giving the mobile numbers and the emails of the team members, okay, with whom you can connect separately if you have any interest in tele ICU monitoring. There are various kinds of monitorings that are done. One, which is the most basic one, is called the night monitoring, where we just monitor these patients through the night. So suppose you're going home at 6 o'clock, you'll just inform the consultant specialist at the command center that I'm going and these patients need to be monitored, and these will be monitored through the night for your convenience. This is the basic system. The second, which is a better or an upgraded system, is where apart from night monitoring, you can also get a consult in the day. So the round happens in the day. The benefits is that the consultant knows that which patients to round and what are their clinical condition, because they have rounded on the patients. So these are the two models which are available right now, and you can connect with any of the teams to consider these models. Okay. What are some of key requirements to consider for a new hospital project so that they can digitize and connect at some point, even if they don't have plans to invest in digital solutions immediately? Now, if you are building an ICU and if you don't plan to digitalize immediately, at least certain things can be done in the project phase, which are not major things, but doing those things again once the project is over will be very difficult and will add costs. So certain changes need to be made at the project phase when the ICU is under construction, so that those changes don't need to be redone. Even if you're not considering digitalization immediately, those changes can be done, and then you are ready to do it whenever you want to start it. It also includes buying the equipment which is compatible with tele-ICU softwares. So construction in the ICU and compatible equipment are the two things which you can think of. And at a later date, say after a few months or a year or two, if you really want to start a tele-ICU platform, you don't need to go back to the drawing board and redo all the things again. For diagnosis, a doctor depends on the vitals shown on a monitor, but they also need information on clinical examination. Doesn't a tele-ICU system provide only incomplete information for proper diagnosis? Now, this is a very good question. In this era of intensive care where or in medicine also, where each and everything is becoming digitalized, the reliance on the clinical examination is going down. But it cannot be understated that clinical examination is important. So what we do is that the doctors and nurses, or the doctors with whom we are working, they come to our unit, our critical care unit, and we teach them the basics of critical care medicine. and then they go back to their respective ICUs. So we rely on their examination because they worked with us for a few weeks. And when they go back, we know that they have skills which can easily tell us, and we can rely on their clinical examination. There are devices which are available now where you don't need to touch the patient, and those stethoscopes have come where you just need to put this device at the lungs, and the consultant who is sitting remotely can hear the sounds. We have not tested these devices, but a lot of things are happening. So our eyes and ears are basically these doctors who are working in the intensive care unit and who are trained by us. Are such solutions affordable for the Indian scenario? Much of the hospital equipment available, especially at affordable hospitals, is not standard and may not be able to be connected to the standard tele-ICU system. Now that's a pertinent question because there are two ways tele-ICU will work. Either your monitors and ventilators are compatible or your equipment is not compatible. If it's compatible, very well. If it's not compatible, then there are two ways where you can proceed. One, if you're already planning to change the equipment, okay, or you're planning to upgrade, you can upgrade to tele-ICU compatible equipment. The second, which is not ideal, is that you can buy the software, but then the nurses need to do manual charting on the software. But the downside is that because the monitor and ventilators are not connected to the software, the real-time alarms which we rely on will not come. Because the real-time alarms will not come, so our reach, our chances of catching early warning signs is diminished significantly. And that's why it's very important that we have a tele-ICU compatible equipment. Although even without that, it works, and we are already running few ICUs where the equipment is not compatible. Okay, there's this question. How can tele-ICU be helpful in most emergency cases in rural areas? Okay. Now, there's a study which was published actually by I think by the government, where they found that in the rural areas the shortage of doctors is the maximum, and I'm sure everybody would have read enough on Google about it. Almost to the tune of 80 to 85% is the shortage of surgeons, physicians, specialists. Can you imagine? Huge shortage. And in rural areas, one will never be able to overcome these shortages. So yes, tele-ICU can be a beneficial beneficial way to manage emergencies in the rural areas. It doesn't need a very hi-fi system. It needs to be a simple system, because whenever we talk to our colleagues in the government, particularly in the rural areas, what happens in the rural area? A patient goes to PHC. From the PHC, the patient is referred to the CHC without any interventions. The patient reaches CHC, he is referred to the district hospital without any intervention, and then finally reaches the medical college. So that's why our medical colleges are overloaded, because the colleges are looking after those patients which can easily be managed at the district hospital or community health center or primary health centers. So if you are able to give these systems or manage those patients through telehealth means, I'm sure the referrals from PHCs and CSCs to medical colleges will go down, and we can decongest the medical colleges, what every government wants now. So yes, it can be helpful. Do you or GE provide doctor services or only software and hardware only? No, this is a clinical service solution. So it is actually about the hardware and software is an essential part of it, but mainly tele-ICU is a clinical service. So there are doctors and nurses who are managing patients remotely through the tele-ICU. How confident you are that the night rounds are efficient in tele-ICU, and as these are most problematic for us in smaller areas, And there's another question, but just by night monitoring, how emergencies will be attended to? Now, I'll tell you how it works. You have to understand how the concept of critical care works. Most of the time in critical care, you are looking at early warning signs. You are not, when a patient comes in the ICU, our main aim is not to find out the diagnosis. Our main aim is to correct the pathology or to correct the physiology first. We try to find a problem, solve it. We find second problem, we solve it. The conventional teaching of finding the diagnosis is not the way we run intensive care units. So let me give you an example. Suppose you are at 2 a.m. in the night and there's a sick patient who comes in a smaller ICU. Now, if the ICU is connected to the command center, as soon as the nurse attaches the monitor, the data starts flowing into the command center. So a pop-up alarm will come into the command center that in so-and-so city, in so-and-so ICU, in so-and-so bed, a patient has been received. So you immediately are alerted by that pop-up. Now, once the patient's data starts flowing in, you're not physically looking at the patient. You are only looking at the backbone is the alarms. You're looking at the patient through the alarm system. Once you have seen the patient, talk to the doctor, given an advice in the night, you will keep a watch on that system. What happens is that suppose the heart rate goes up or suppose the heart rate goes down, the alarms will come in the command center. The doctor will call up the unit and explain, look, I am seeing a change in the heart rate or I am seeing a change in the oxygen levels. I think you should do these 2-3 things. And that advice is immediately sent in an electronic format. Okay. So yes, as I told you, in the night talk, in the emergencies, because you are mainly managing you are responding to the alarms, you are responding to the alarms in a faster way. That's why even night emergencies can be taken. The model which works in US is actually they don't take rounds on these patients. They only respond to alarms. They never take rounds. While we do take rounds on these patients, if the unit has opted for day rounds also, but if you look all across the world, they only respond to the alarms or the ECGs or the hypotension or the tachycardia. Okay, so you have been the pioneer of tele-ICU in India. As per your opinion, what are the few apprehensions that small clinics have while setting up tele-ICU with command center, and how do you overcome those? Well, there are a lot of apprehensions. I'll tell you first apprehension. The first apprehension is among the doctors and the nurses. They feel, oh, is it something like a Big Brother show now and somebody is watching us, and they actually feel insecure, non-confident, and sometimes they feel, and when we started, we encountered it in a big way, where they would actually not tell us the data. They would stop sharing the data because they were worried that they will expose the inadequacies of the system. So whenever we are starting a tele-ICU, the team goes there, we talk to the nurses, we talk to the doctors and explain them that, look, we are a part of your team, and it's our responsibility to upgrade the system. Now, there are always flaws in every system. No system is perfect. So don't think of it as somebody who is going to finger point at you or bring your flaws in a public domain. It's just that we are working to improve the patient care. There are some sessions that we do with them, and then this problem is taken care of. That's the first apprehension. The second apprehension is about the costs, because when we go to the smaller units, they have to be very clear what are the benefits in patient management, and also the benefits in the financial tangible terms. So these discussions are mainly with the hospital administrators, and we have to explain them the benefits that they'll get from tele-ICU. So at this point of time, these are the two main challenges that we find. Are remote area people aware of tele-ICU? Well, I cannot answer how many remote area people are aware about it, but yes, webinars like this, if we can attach more and more people, I'm sure more people will become aware about tele-ICU. It's a novel solution. It's a good solution. I think it's a solution which can actually help remote patients in the best way. This is not a solution made for bigger cities. It's not a solution made for cities where you have a critical care specialist. It's not a solution for ICUs who have specialists in their ICU. It's a solution tailor-made for those people who don't have a critical care specialist, but they still want to give good critical service out of their hospital. So yes, if we can aware more and more remote people, I think the benefits will be more. How many patients can a remote consultant ideally handle? Will it overload the capabilities as the system scales up? I think yes, this is a very, very good question. A doctor sitting in the command center, a consultant, is a human being. He's not a superhero, he's not a supernatural powers. So he has his limitations, which are more mental limitations, because he's not doing a physical job, he's doing a mental job. So in our model, I'll give you a hypothetical situation. Suppose there are 100 beds attached to the command center, okay? And out of these scenario, 30% are most critical ones. 30% are of, I would say, mediocre criticality, and 30% are more or less stable. That's the general trend of intensive care. So what the doctor does is that he's concentrating more on those 30 patients. Now, there's a caveat. These 30 patients he will concentrate more on because he knows that they can destabilize anytime. While the alarms are coming from all the 100 beds, and there's something called as alarm fatigue, which if you go into the literature, into the medical literature, you'll read a lot about it. It happens to the nurses and the doctors working in the ICUs, where they stop responding to the alarms. So yes, since they are responding to the alarms, they are more concentrating on those 30 beds. But the other 30 can also deteriorate. So they are in the radar, but they are not being actively monitored. The consultant is not alone. There are two critical care specialists, nurses also, who are monitoring these patients. So it's a team of 3 people who are actually managing these patients. They can monitor to the maximum of about 75 to 80 patients. But that also, as I told you, if the criticality of the patients is more consultants needs to be added. And yes, the next question is, will it overload the capability as the system scales up? Yes, there's always a chance of when you scale up, you have to make certain changes into the system. Well, I don't think it will overload the system, but yes, look at the conventional way of running an ICU. If you are running an ICU of 100 beds, you will need at least 20 to 25 member team. Right now in this model, you have all the junior doctors there, but there are no consultants. The consultants which are there, if I may take a model of 100 beds, you will need at least 9 to 10 consultants minimum to run those 100 beds. In a tele-ICU, if you have trained the junior doctors in a good way, these 100 beds can be managed by 2 consultants. So it immediately decreases the cost to 20%. And that's how the system would work. Okay, I think last question. Do we have anything here? Okay, this is the last question. Are there any differences technique between tele-ICU and ICUs in metro cities? And if Yes, what are they? Well, the techniques of critical care don't change whether you are running an ICU in a metro or in a tele ICU model. The only thing that changes is, one, the consultant who is supposed to be ideally present in front of the patient, the specialist, is not there, and he is actually looking at the patient from some remote site. Like we are talking to each other. This is only one-way communication. If you have a two-way communication, it is easily manageable in this era of digital healthcare where you can see these patients. Sometimes we do get requests from the doctors to actually talk to the family members of these patients. So we even do counseling sessions, not very frequently, but upon special request, we do counseling sessions for these critical patients to the families also, particularly when they are thinking of coming all the way to the metro station, to the metro cities to manage these patients. So I think in this era of digitalization, we can take benefits, but fundamentally the way you run any intensive care unit or you run tele-ICU, the fundamentals won't change. Okay, with this, I think we come to the end of the webinar. I'm thanking you all for the active participation and such nice and beautiful questions. Some of them even have put some thoughts into our mind on how we can run the systems more efficiently. Thank you very much and good night.